Buenas tardes a todos, es un placer para nosotros recibirlos al lanzamiento de nuestros nuevos productos Ketovie 3.1 y Ketovie Peptide. Antes de comenzar, queremos agradecer a Laura Doherty, Marisa Armeno y Rebecca Jennings por las interesantes exposiciones que van a presentar hoy, a Hinomoto Cambro por el apoyo que nos brinda siempre y a todos ustedes por conectarse y participar de este webinar. Les recordamos que cuentan con un botón para preguntas y respuestas. El mismo se encuentra en la base inferior de la plataforma, y las preguntas serán respondidas al final de las exposiciones de los oradores. También cuentan con un botón de chat, este está únicamente para cualquier problema técnico que tengan durante las exposiciones. También contamos con un botón para la selección de idioma, el mismo se encuentra al desplegar el borde inferior de la plataforma en el extremo derecho. Allí podrán seleccionar el idioma que deseen escuchar entre inglés y español. Asegúrense de no cliquear el botón mutear el audio original. Si lo hacen, podrán escuchar el idioma original cuando coincida con su elección. Permanezcan en la opción del idioma preferido durante todas las exposiciones, independientemente del idioma hablado por los disertantes. El contenido se traduce inmediatamente al idioma seleccionado. Así que bueno, luego de todas estas explicaciones técnicas, vamos a dar comienzo al lanzamiento dándole la bienvenida a las oradoras. Tenemos el honor de contar con la presencia de Laura Doherty. Ella es nutricionista especializada en dieta cetogénica durante los últimos 12 años y coordinadora del programa de dieta cetogénica de la Universidad de Medicina de Carolina del Sur. Sus principales estudios y papers se focalizan en la terapia cetogénica en niños menores de 3 años. Laura se graduó en la Universidad de Purdue, donde obtuvo su graduación en Ciencias de la Nutrición y Dietética y completó su capacitación como nutricionista registrada. Laura también es presidente de la Keto Hope Foundation, una organización no gubernamental que brinda soporte a familias y capacita a nutricionistas. Ha realizado numerosas presentaciones en diversas conferencias y congresos sobre dieta cetogénica y es asesora del contenido de las guías prácticas realizadas por la Academia de Nutrición y Dietética sobre dieta cetogénica clásica y modificada en el tratamiento de la epilepsia refractaria, publicada en el año 2017. Laura es miembro del Grupo de Trabajo Internacional, creador de las guías de epilepsia refractaria en el lactante en el año 2016. Laura Doherty expondrá sobre dieta cetogénica, utilización en lactantes y niños pequeños. Bienvenida, Laura. También contamos con la amable presencia de la doctora Marisa Armeno, médica pediatra especialista universitaria en pediatría y nutrición infantil, médica de planta permanente del Servicio de Nutrición y coordinadora del equipo interdisciplinario de terapias cetogénicas para epilepsia refractaria y enfermedades neurológicas del Hospital Garrahan. La doctora Armeno expondrá sobre indicaciones del uso de fórmulas hidrolizadas en terapias cetogénicas para epilepsia refractaria. Bienvenida, Marisa. Finalmente, contamos con la agradable presentación de Rebecca Jennings, graduada en la carrera de Ciencias de la Nutrición y los Alimentos, con un máster en dicha carrera. Rebecca es nutricionista registrada y especialista certificada en nutrición pediátrica. Ha ejercido en el área de clínica y académica como nutricionista especializada en errores congénitos del metabolismo, dieta cetogénica y otras especialidades pediátricas. Actualmente es empleada de Hinomoto Cambro como especialista clínica en nutrición cetogénica y metabólica. Rebecca expondrá sobre Ketovie 3.1 y Ketovie Peptide, alimentos para propósitos médicos específicos. Bienvenida, Rebecca. Con la presentación de estas 3 excelentes oradoras, damos inicio a las exposiciones. Laura?
Great, can everybody see my screen okay? Great, thank you so much for the introduction. Today, I'm going to be discussing the recommendations for the ketogenic diet for infants and young children. I'm going to highlight some of the formula features that I personally like to use in infants and how to incorporate breast milk into infant plans. I'll discuss my process for transitioning infants and young children onto keto, and I'm going to go over 3 case studies where I specifically use Ketovie 3:1 in this population. In 2016, a group of experts put together specific recommendations for children under 2 years old. These experts represented several different countries, so they compiled their knowledge from across the globe. When the group was surveyed, it was found that most centers use the classic ketogenic diet at a 3:1 ratio, including a hospital admission for initiation, and a non-fasting approach for this specific population. Energy, protein, and fluid requirements agreed upon by the experts are listed here for your reference. The group determined that all vitamin mineral needs should be assessed individually. This is of particular importance when you are weaning off formula and onto food, keeping in mind that the formula options are fortified, so when you're decreasing the formula, you're also decreasing the fortification. The last recommendation of the group was a glucose checks should range, depending on who you asked within the group, 2 times a day, all the way up to 2 hours during the transition. So the average amount of time the glucoses were checked was twice a day. Levels below 40 should be treated, and several different treatment options were listed in that recommendation paper. But ultimately, the group decided that treating with 2 to 4 grams of carbohydrates from either breast milk, formula, D10, or juice for infants over 4 months old was appropriate. So in terms of preparation for your infant population on a ketogenic diet, prior to initiating, of course, it is important to get a neurology consult and to have the seizures confirmed on an EEG if possible. Some examples of infant-related diagnosis commonly treated with keto are listed here. I'm specifically going to talk later in my case studies about an Ohtahara syndrome patient and infantile spasms. If possible, a genetics consult should also be completed to help rule out any contraindications. If a geneticist is not available, it's doing just some genetic labs in terms of metabolics would also be okay to rule out these contraindications. Baseline labs, these are the baseline labs that are agreed upon with the consensus group and also the ones that we utilize in my own program. Please keep in mind the volume of blood needed and the age of the infant. This is particularly of importance if you're doing any keto therapy in the NICU. You may not be able to get all of this blood work done in one draw. It may have to be done over the course of a few different days in order to not take all of the infant's blood. Medications, if the baby is on any IV dextrose-based medications, that should be removed from the diet. And then changing any type of medication that's in a liquid form to a tablet if possible. Now, with infants, this can be rather tricky because the doses of the medications may be very, very small, and therefore a tablet version of the medication may not be possible. So at the end of the day, if you cannot switch to a tablet medication because the dose doesn't make sense, that's okay in most situations because, again, the doses are small. So usually the carbohydrates that sometimes are found in the liquid medications might be able to be worked into the diet. The other option that we can sometimes use, but is not always available, is using a compounding pharmacy that can specifically make the medications in a keto-friendly format. And finally, and this is where myself comes in most integrally, is the nutrition consult. So when I get a consult for keto, I'm looking at, okay, what is the child's baseline calorie intake? How much protein are they getting? What's their feeding schedule? And how are they growing? From that information, I work out my keto plan. So the initiation process is very similar to the older base kids that maybe you have experience with doing keto for. I transition my kiddos 1 ratio point every day. So I may do 1-to-1, the next day 2-to-1, 3-to-1, and so forth. Or I might start at 1.5-to-1 and then go to 3-to-1 and then 4-to-1, depending on the situation. I do not fast any infants in my program, keeping in mind that fasting infants may get you to ketosis faster, but long-term outcomes are not always, it doesn't have any benefit in terms of the long-term outcomes in my experience. Always collaborate with all team members. It's important that you don't sabotage yourself when starting a keto diet by not communicating clearly what you're trying to do. So making sure that the nurses understand when it's appropriate to treat a low blood sugar and how it should be treated, because it's going to be very different than what they're probably used to. Also making sure you involve the pharmacist in terms of getting the medication carbohydrate counts and also conversions of tablets, again, if it's possible. And fourth, I can't emphasize this point enough, you are going to have to adjust the plan far more frequently than you do for your older children. Calories, protein, weight gain is going to be monitored very frequently, at least daily when you first start, and then as the child ages up, you can do it weekly and monthly. But these adjustments have to happen a lot more often than some of the other patients we're used to following. These are the labs that we check during an initiation for the ketogenic diet. So the glucose ranges is going to be 40 to 100. I will be honest, at MUSC where I work, we actually treat blood sugars at the level of 50. My facility is not comfortable letting infants go down to 40, so we have chosen 50 as our cutoff. This is fine. Whatever your facility is comfortable with, go with that. Because the consensus of the group of experts that wrote the paper, these levels were all over the place. Some were 40, some were 60. Check every 2 to 6 hours. My program checks every 4 hours. And then checking every 12 to 24 hours once the goal ratio is being given and tolerated. Treatment guidelines, if the blood sugar is under 40/50, so whatever your threshold is going to be 15 mLs of juice if they're above 4 months old, or 30 mLs of express breast milk or formula. Both of those end up being about 3 grams of carbs. I also educate my nurses, if the infant is due for a feeding and a blood sugar check at the same time, always feed the infant first and check the blood sugar 15 to 30 minutes later. That way you're not inadvertently giving too much carbohydrates when the child is then going to eat shortly after. Bicarb goals is, for my program, I aim for bicarb levels above 16. If we need to treat a bicarb level, we will generally do it with sodium bicarb tablets or IV bicarb if we have IV access. Ketone levels, my goal in the blood level is 2 to 3, and that is millimoles per liter. And then in the urine, it is moderate to large. There are some infants that do not produce urine ketones very easily, although I will not say it is the norm. Most infants will produce urine ketones, but there seem to be a small cohort of patients that don't. So I always follow blood levels first and foremost, and urine ketone levels secondary. In most cases, when I'm considering an infant formula, I want a product. So I've kind of listed here mandatory, consider, and avoid. So I really want a product that is unflavored, that doesn't have any artificial sweeteners, and contains DHA and ARA, and works well with express breast milk. Keep in mind that infants, especially young infants, are not used to flavors. So it's important to choose a more bland formula. It's not to say that they won't take or enjoy a flavored product. It's more of a situation of if the diet doesn't work and you resume breastfeeding or regular infant formula, will they take that particular formula or breast milk after you have introduced them to a flavor? In addition, in my experience, flavorings may sometimes cause an increase in reflux, which is something we often see in keto for babies. Other considerations that are a more individualized thought process is, what is the protein source of their baseline formula? So when they come to me, what type of protein are they used to consuming? Is it whey? Is it casein? Is it whey and casein? What ratio is my goal? Do I want a lower ratio because I'm worried that this child might have some hypoglycemia? Have they just come off of steroids? So oftentimes I'll see babies that are coming off of high-dose steroids for infantile spasms, and I need to keep that in the back of my head that they may have some glucose issues. How are they stooling, and would MCT benefit them? So those are all things I'm thinking about when I'm choosing an infant formula.